Thank you, chairpersons. Thank you, moderators and speakers. We move to next session. And for this, I invite Dr. Benny Jose, Dr. Anand Ahuja, Dr. Nikunj Koteja. And to chair, I invite my friend from Delhi, GB Pant, Dr. Girish MP, Professor Kamath from Bangalore, and Dr. Jignesh Kothari from Yan Mehta. Over to chairpersons to introduce the speakers.
Thank you, Dr. Kamal, for the invitation. I think the conference as such is doing wonderfully well with a lot of debates, and I was part of. I was looking at the debate earlier two debates, which were fought with the right vigil and right my state of mind, so that our patients at the end who are the ones who are going to benefit with these things. So again, the topic for this is very well chosen, and this is regarding a 65-year-old female patient with unstable angina and triple vessel disease. So unstable angina for this admission, and there was an history of TIA with some obstruction in the left carotid artery on carotid angiogram. So I would invite Dr. Karthik Patel, who is MS from PGH Chandigarh and MCH from All India Institute of Medical Sciences. He is presently Associate Professor of CVTS in Yan Mehta, and he has many publications under his achievement. And he is on the editorial board of Journal of Surgery Forecast, as well as World Journal of Surgery and Research. Dr. Karthik, please. So the second speaker would be Dr. Rahul Gupta, who is MD Internal Medicine and DM Cardiology from Mumbai. And he is consultant cardiologist at the Apollo Hospitals, Navi Mumbai, he has more than 15 years of experience in field of cardiac sciences, and he is proficient in handling procedures like primary and complex angioplasties. He has been a recipient of various awards and accolades, and he has a lot of publications and research to his name. So to begin with, I would invite Dr. Karthik Patel to delve on his lecture.
Am I audible? Hello?
Yeah, you are audible and visible. Your slides are visible.
Yeah, my slides are visible to all of you?
Yes, Karthik, please go ahead.
Okay. Very good afternoon to all. Thank you, Kamal sir, for giving this opportunity to present this scenario in this beautiful academic fest. So index case is 65-year female. She has TVD with unstable angina with minor dysfunction. She also had left-sided TIA 3 months back, and on evaluation, she had found 95% stenosis in right internal carotid with mild disease on left. So there are multiple questions which has to be answered before treating this patient, like whether she required coronary intervention or not, whether she will require carotid intervention or not, and if required, what will be the timing and the sequence of the intervention. As you all know, I am a surgeon. There is always a bias treating this patient. However, in these presentations, I would try to justify what is the best option available for her by more focusing on facts as compared to beliefs. I think this patient will definitely require CABG, and which has been supported by many guidelines. Even recent AHA has supported this. Before going further, just small, very quick recap of carotid artery stenosis. It can be defined as symptomatic and asymptomatic, depending upon presence of symptoms. If the symptoms are within 6 months, then it is called as symptomatic. If the patient has symptoms of more than 6 months, then it is called as asymptomatic. Another classification is presence of a stenosis, degree of stenosis of internal extracranial internal carotid artery. Depending upon that, it can be classified as mild, moderate, severe, or complete. Why it is important to know for us? As you know, this patient will require CABG. So a very beautiful article by Nailo says that risk of stroke after CABG is proportional to a degree of a stenosis. So if the patient has more stenosis, she will have a higher risk. And it is important to note that around 23% of patients will die. So not intervening carotid will lead to high risk of morbidity and mortality in this particular patient. Even recent guideline says that a patient, symptomatic patient with symptoms, with a 50 to 90% of degree of stenosis ICA should intervene. Carotid has to be intervened, but they have told that method, timing, and the sequence will depend upon the patient's conditions. So, what intervention available for carotid we have? As you all know, the aneurysm, which is the oldest and most commonly performed procedure worldwide, and second is stenting, which is gained popularity nowadays. When talk about isolated carotid artery stenosis, we have multiple RCTs comparing both of these. They are mainly industry driven or a controlled RCTs. These are the some industry driven carotid trials, out of which Sapphire was the most important one. It has shown a non-inferior of stenting over to carotid endarterectomy in a patient of high risk. However, there are many caveats. One, it is heavily industry influence. Second, there is some amount of selection bias because out of 700, only 334 were included. Third, 25 patients on both arms were died. And there is also a controversy about definition of MI, leading to a more cases in both arms. There are other randomized control trials like ICSS, EVA, 3S, even SPACE. They have all shown a CA is better as compared to stenting. The most important, even ICSS has shown that around 50% of the patients which are undergoing CS has having new MRI finding compared to aneurysm. The most important and most talk about this is Crest Trial. Even Crest Trial has shown that stenting has little amount of increased pre-procedural death as well as stroke where compared to aneurysm, especially in a patients of more than 70 years. They have also published a long-term data of 10 years. In this data, they have shown long-term aneurysm versus stenting is both are equivalent results. However, when we do a subgroup analysis, you can see the risk of stroke is more in a patients with more than 65 age, symptomatic, and a female patients. So our index case is female of more 65 year with symptomatic. So in this case, aneurysm will definitely give a better short-term as well as a long-term results. These are the recent meta-analysis which summarize all these studies and which have showed similar results. Based on these findings, these are the recommendation by European which shows that aneurysm is a class 1 indication with level of recommendation of A. There is also a role of stenting, but they have given a class 2A class with a level of evidence of A. What are the indications? When a patient is very high risk of because of cardiac or pulmonary disease, or more age is more than 80 years, in a recurrent disease, patient having previous radiations, or a patient having bilateral disease. Even a recent stroke guideline have confirmed that aneurysm remains a class 1 indication with a level of evidence of A. However, if the patient needed both, then what will be the timing and sequence? It will depend upon three important questions. That one, which vascular bed is more symptomatic? What is the anatomy? And what are the individual risk factors? Depending upon that, sequence will be concomitant, that is performing the procedure simultaneously. Stage, that means carotid intervention followed by coronary interventions, or it is a reverse stage. That means a coronary first followed by a carotid second. So what are the general indication for concurrent approach? If the patient is symptomatic for both, severely symptomatic for both vascular bed, then that patient will require intervention of both. Like in a cardiac, if the patient has unstable angina, just like our index case, or severe LMC disease, or TVD with liver LV dysfunction, or critical LED lesion. Along with if patient had symptomatic stenosis, symptomatic carotid stroke or anything with a stenosis of more than 50 degree, or asymptomatic with high risk carotid, that is bilateral involvement of more than 80%, or a one side total occlusion and a significant lesion on one side. then this patient is more suitable for concurrent approach. If the patient has more severe symptom for carotid, then it is better to have a stage approach. Or if the patient has more symptom on coronaries, then it is better to have a reverse stage approach. So our index case has a symptomatic severe carotid artery stenosis with unstable angina. So she is best suited with combined approach. But there is still a choice, there is still a lack of data when a patient undergoing CABG. So what intervention is we have to choose between stenting or carotid artery in a patient undergoing CABG? There are no RCTs available. The data available are prospective observation studies, or most of the time it is retrospective. There is also heterogeneity of the population. Like they have included symptomatic as well asymptomatic patients for carotid, as well as they have included patients with stable angina, unstable angina. Also, the timing of intervention is different. Like they have mostly compared a concurrent angiography versus a stage stenting, or they have compared a concurrent stenting or angiography versus a stage angiography or a stenting. In this beautiful article, which is I got largest of patient, 22,000 patients by Fieldman et al., published in 2017, shows that angiography remains a most frequently performed procedure, but it has a least stroke rate, but it has a higher mortality rate compared to stage stenting. A recent meta-analysis also confirmed the same finding. It has shown that the risk of death is more when you do a concurrent angiography with CABG compared to stage. Also, but in this meta-analysis, they have also do subgroup analysis, and if they remove the patients with Feldman, they have shown that the mortality benefit of stent was vain. Whatever the benefit, when we see these results, it has been shown that we perform concurrent angiography or stenting, the risk of death or stroke will be higher, like around 6 to 10% when we do both. Why? Because in these studies, most of the patients underwent on-pump CABG. There are no data of, they have very less amount of the patients are underwent off-pump CABG. Based on these findings, the European have given a recommendation of angiography along with CABG in a symptomatic patient with a high degree of stenosis with a class of 2A and a level of evidence of B. They have not talked about stenting yet here. But important to note in India that we are routinely performing off-pump CABGs. And there are multiple data are available which shows when we do concurrent angiography with off-pump CABG, the stroke and death rate comes to less than 2% or equivalent to 2%. That is a patient, that is the same as a patient undergoing CABG without any stenosis of the carotid. So my preferred approach in this patient will be angiography and off-pump CABG simultaneously. So my take-home message is, still there is a scarcity of data. Current evidence still leans towards the angiography. Combined in this particular patient, combined angiography and off-pump is preferable to have better short as well long-term outcome, least MI, least death, and least stroke rate. There is still role of stenting in this patient if it is not a candidate of angiography. Thank you.
I think very well put, Dr. Karthik Patel. And now I would like to invite Dr. Rahul Gupta for his talk on the same topic.
So good afternoon, everyone, and thank you for having me here in CardCon, Dr. Kamal. And I think Dr. Karthik has presented his facts very well, and I think this debate is going to be there even after we finish our points. So let's see whether carotid PTA prior to CABG would make things easier, and let's see whether Karthik can join hands on the other side in the red corner. So we'll try to raise the bar. So we have seen this. I think the things have already been discussed. Our patient who is little youngish, around 65 years old, and female with unstable angina, so requires solution for both the vascular bed. So I think I will go into the review of literature where I think Dr. Karthik presented the Crest data from the Crest, which is the longest 10 years data of a lot of patients. But whatever data numerically, even though it was on the better side of the CAE, but it was statistically insignificant. I'll just point out that. Then there are certain studies which I'm going to regarding the timing, because this sequence, whether reverse stage with CAS, with CA is all, there are a lot of studies which are available, a lot of meta-analysis are available. I went through a lot of literature, and you can get all the literature of every kind, but we'll see our patients fits into the which category. And we'll study the high-risk patient characteristic and benefit. We'll see whether our patients has any of the high-risk characteristic and contraindication to one of these or not, or whether it is feasible for both, and then finally we'll conclude. So I think the dilemma is going to be always there as to how to approach this patient, and because in about 8 to 14% of patients, there is concurrent carotid artery stenosis in a patient who is undergoing a CABG with triple vessel disease, especially if they have a left main involvement. And as Dr. Karthik rightly pointed out, there is always has been debates as to the sequencing and timing. Both the vascular bed will require one of these approaches. So these approaches have been discussed by Dr. Karthik, so I will not go into the detail, but today's topic is more of carotid PTA before CABG versus same setting CA with CABG. So the Crest trial, I would like to again emphasize about this trial which Dr. Karthik pointed. The summary of this Crest trial was that 10-year result demonstrated that stenting is as safe and durable as surgery at 10 years, which is a very long-term study. There were 2,500 patients, 1,607 consented for long-term. And finally, there was no significant difference between stenting and surgery patient in primary composite endpoint. So I'm talking about the statistical significance. Numerically, as we saw in the graph, the pointers were slightly towards CA, but what is we are more interested in the statistical significance. Similarly, there was no difference between symptomatic and asymptomatic patients and in the rate of restenosis or revascularization. This is the detail of the study where there is no significant difference between CAS and CA over the 10-year follow-up period, statistically not significant. In fact, if you look at the post-procedure long-term 10-year stroke, the symptomatic 5-year rates at 2.5% for stenting and 2.7% for endarterectomy are very low, especially when compared to the medical arm from the NESCAT trial. And if we look at the asymptomatic group undergoing CAS-CE, symptomatic CAS-CE, so event rates were low and similar in all 4 groups. So my point is, when the event rates are equal or low in both groups or statistically insignificant, what is in this current scenario where we are looking for minimally invasive procedures to look for a procedure which will give us minimal thing. This is the graph which Dr. Karthik also pointed out. Across various age groups, across the male, female, status, stenosis severity, the statistical significance p-value for interaction has been insignificant. So this is what I wanted to point out. So what was the conclusion from this Crest trial? Post-procedural rates of stroke for stenting and surgery are similar and they are very low. There are no interaction between the treatment and symptomatic status, and Crest long-term composite results are similar for stenting and surgery over a time horizon appropriate for elderly patient with severe carotid artery stenosis. Now, this is a study of 20 patients. These are just pointers that people are studying, and there have been a lot of such kind of studies. I just put one of these studies where the discussion was about the hybrid procedure of CAS and CABG, and whether it decreases the risk of stroke and other complications was the subject to study. And it was concluded that the hybrid procedure of CAS and coronary surgery might be a good therapeutic option. And they studied in details, and it was CAS was successful. There was in the clinical outcomes in both the groups, there was no statistical significance as far as both the arms were concerned. And what it proved is CAG and CBG procedure were performed separately in the study time delay of 2 points. This was done intentionally in order to assess the neurological status. So this point is also important. When we do a little stage, we know the neurological status of the patient from the carotid procedure versus the CABG itself has a risk of causing a stroke because of the various reasons. So this also helps us when we do a stage, prior procedure and then take it up for this thing. When we do a symptomatic patients, carotid endarterectomy, these are the patients at much risker for having a coronary MI and post-procedural MI, and the trials and meta-analysis have shown. Now, this is one study, meta-analysis of 5 studies, including 16,712 patients, where they compared the synchronous CA and CABG versus stage carotid artery stenting and CABG for patients with concomitant CAD, which is the case in our discussion today. And the conclusion was that this meta-analysis did not detect statistically significant differences in the rate of perioperative stroke, TIA, and MI between the group. However, patients in the simultaneous CA and CVG group had a significantly higher risk of 30-day mortality. So similarly, if you look at the timing of synchronous versus stage carotid endarterectomy and coronary artery bypass grafting, whether we should do a stage CA and synchronous, we find that this was of 11 studies comprising 44,895 patients, and the patients in the simultaneous CA and CVG group had a significantly higher 30-day mortality and stroke and lower risk for MMI as compared to the stage C and CVG group. So again, this data. Similarly, there have been study about the synchronous stage carotid artery stenting versus during the bypass surgery during the same time, and there were 4 studies comprising 357 patients. The simultaneous approach was associated with an increased risk of 30-day stroke compared to the staged CAG and CABG. However, no statistical significant difference was found in long-term results of mortality, MI, and stroke. What I'm trying to tell you through these meta-analysis and the studies is that simultaneous the surgery are related to, most of the studies which I went through are related to increased mortality over 30 days. And this was an article from the e-journal of ESC Council of Cardiology Practice, where they compared both these strategies of treatment of carotid stenosis before the coronary artery CABG. And they found that the complication rates in patients who have undergone carotid angioplasty and stenting followed by CABG is significantly lower than in patients who have undergone combined carotid endarterectomy and open heart surgery. And the meta-analysis of 30-day outcome following stage carotid artery stenting before coronary bypass surgery showed that carotid artery stenting plus CABG is an attractive and less invasive alternative to carotid endarterectomy plus CABG. Similarly, about the risk of operative procedure, what they concluded is that the option which combined carotid endarterectomy and CABG is related to higher stroke and death rates of 7.4 to 9.4%, which is nearly twice the risk of each operation alone. Now, these are some high-risk features of CA and CAS. We should see whether our patient has any of these anatomic or comorbidities. So our high-risk patients for CEA, in fact, unstable angina has been considered as a risk factors for high-risk factor for CA, especially if you do a staged CA, and the simultaneous one we know is associated with more mortality, which we went through all the papers. Now, if you look at the high-risk features for carotid artery stenting, this patient does not have any of these anatomies described in the thing, and it looks pretty simple. The age is 65. The possibility of tortuosity is of the vessels, vasculature, bovine arch. All these are little less, which will make the carotid artery stenting more simple and easy and feasible. So these are the advantages: less invasive, no risk of potential cranial nerve injury, no arterial incision needed, shorter hospital stay, lower risk of myocardial infarction. We don't have the risk of kidney injury in this patient because this patient doesn't have any CKD. This patient appears to be suitable for DAPT, nothing mentioned in the history. And there is a higher risk of stroke which has been described, but these risks are non-disabling stroke. This is what I went through the literature, that the disabling strokes are equal on both the sides. So the advantage of CAS plus CVG approach include immediate awareness of the procedural results in an awake patient, shortening of the hospital stay, less invasive procedure, and even more acceptable cosmetic results. Looking at our the female in our discussion, the efficacy and safety of CAS and comparison with surgical procedure were extensively studied. A recent meta-analysis showed that overall, in short-term, CAS patient developed more strokes and less MI than those undergoing CA, but the incidence of disabling stroke and death is similar. So this is most important. And the Crest and Space trials have shown promising results. And from finally, everyday technology improvement, which is happening in stent design, structure, use of protection device, might influence further results in a positive way towards CAS, notably in stable patient with carotid artery disease. So let us look at this patient, and why I favor carotid PTA in this patient is is a relatively young patient, so vascular tortuosity, calcification, arch anomalies are less likely, which will make my carotid artery stenting much simpler. No renal issues, so no risk of AKI. Anatomy seems favorable as only right ICA is involved. There is no bifurcation mentioned in the thing. Cosmetically better, which is at 65 not better, but I think one of the point again in favor. I think we get the chance to evaluate the neurological status in stage procedure, which is not possible in synchronous procedure. And the literature review meta-analysis, which I went through, maximum studies are now favoring this approach. Technology has advanced. The cerebral protection device also are being used. The improved outcomes in CAS plus CABG over time can likely be explained, and which the meta-analysis and recent studies are showing that it is improving, and it has overtaken the CEA, especially in this kind of patient scenario. It can be explained by more widespread use of embolic protection device and more experienced interventionist. So coexisting carotid and coronary artery disease is common, and the timing and sequence of myocarditis is controversial. This was discussed in detail, which vascular bed is symptomatic, which approach anatomy, I think this we discussed. So both approaches are valid. High-risk feature which increases the chances of complication should be studied for both strategies, and therefore individual important needs to be discussed in heart team. But that centers and operators experience is also important. In a given case scenario, my choice still would be carotid PTA before CABG for all the reasons I enumerated. And I think surgeons and cardiologists are a heart team. And I think for this case, I would request Dr. Karthik to come on my side. I've raised the bar, I've raised the carotid PTA, I've made the bridge. So welcome, Karthik. Thank you so much.
Thanks, Dr. Rahul, for your kind words. And I see you wearing blue and inviting the blue team, that is surgeon team, towards you. So that's a nice gesture to begin with. And it was a nice talk, and with a lot of facts and other things. My only question would be, Rahul, if at all, if there is a problem with prolonged hypotension following your stenting, so would that not undermine the cardiac event which is acute right now?
Yes. So exactly. So I think we have to be very careful and very vigilant for these patients for next 48, 72 hours. We keep them in ICU. We stop their antihypertensive. We make their... So all those things, I think those care need to be taken, not over dilating and, not stretching the carotid bulbs and all that area. I think that can be managed. Most of the time we do it. If we manage it well, pre-operatively, pre-procedure, I think they do well. That's what my experience is. But those points are very well taken, and we need to consider whenever we are dealing with this kind of scenario.
Looking at the the stroke rate, which was shown by Dr. Patel, by Naylor et al., despite a patient having 99% stenosis in unilateral artery, and the other artery is by and large normal, so the event rate is only 3%. Can we just go away with the coronary procedure first and maybe do it later on?
So if you look at a lot of meta-analysis and trials, this is a strong debate. If the patient is completely asymptomatic on the carotid bed, then it will not make much sense to treat the carotid. Just go ahead, keep the carotids on medical management. So this is a discussion, and this is a point of debate also. Based on the lot of literature which is available, that if the patient is completely, because the event rate is very low if they're not symptomatic. But if we consider our patient, this patient has been symptomatic, had a TIA 3 months back. The symptomatic criteria is the patient has an event within last 6 months is called as a symptomatic carotid artery stenosis. So with that, there is no controversy that we need to treat the carotid bed also. But otherwise, I think your point is very well taken, where we can think about, we can discuss and debate and discuss in the heart team about this kind of scenario, where it is just an incidentally detected severe unilateral carotid artery stenosis, where it can be discussed in the heart team.
But again, this event of TIA was 3 months ago, and for all practical purposes, the patient would be on some antiplatelet and statins. Right. So some amount of protection is already been given to the patient. So can we still call that
symptomatic TIA is within 6 months. So symptomatic TIA is within 6 months. If they had an event with severe carotid, is called as symptomatic CAS, carotid artery stenosis.
I would ask my surgeon friend.
It has included just the presence of stenosis, so that the stroke rate is low in that particular study. But if the patient is symptomatic with a stenosis of more than severe, then stroke rate would be a double, I think. Then it's shown in that NILO because he has not included a patient symptomatic status.
No, in the same trial, he
comparing
says
the
that
stenosis and a patient undergoing CABG. He has not included symptomatic or asymptomatic status of the patient. That is now data are coming that in a patient with symptomatic, the risk is higher as compared to patient who is asymptomatic.
Yeah, but
in the same meta-analysis, Naylor has told that approximately 50% of the patients have a cerebral event which is not related to stenosis. Right?
Because
so you cannot. And the second question to Dr. Karthik is, now our friend Dr. Rahul has done a carotid artery stenting. He's on dual antiplatelet. How many of our surgeon friends would be comfortable in doing a CBG at this moment?
That is the bigger caveat that at least 4 weeks that dual antiplatelet has to be started, and it is generally our preference that before off-pump CBG, at least clopidogrel has to be stopped 3 to 4 days before surgery. We generally continue on ecosprin low dose 75, but at least a dual antiplatelet has to be stopped. That is our usual protocol.
In our institute, whatever if the patient, suppose patient requires an intervention and we put a stent, then at least we give them 4 to 6 weeks of anticoagulation. Then we again admit them, evaluate, and then we operate the patient. So usually we give that window period if the patient is undergoing a carotid intervention by cardiologist.
So any more questions from our moderators?
Dr. Benny?
Yeah, I was just pointing the same point out. Although the stroke risk increases, the ipsilateral stroke that has been always told that there is the ipsilateral stroke is not been studied, or it's even in meta-analysis in the latest ones they were actually equal, which means it is still debatable whether the carotid stenosis as such is the reason for the increased strokes. Secondly, the CABG itself we know has a increased risk of stroke. Add to it the bypass or the on pump hemodynamic changes that occur when a 95% stenosis on an ipsilateral carotid, that could bear a slightly increased brunt on that ipsilateral area. But yes, like Dr. Karthik said, the minimal invasive approaches or the off pump ones are probably more safer in such patients.
I think if both are symptomatic, that's when the dilemma arrives. I think the symptomatics always determine what you do first. If your patient had an ACS and had asymptomatic carotid artery disease, things would be easier. If patient had a TIA but it was incidentally found out to have a triple vessel disease, which is a non-ACS, then it becomes easier for intervening the carotids. But when you have a scenario where both are symptomatic or one of them is a critical disease though not symptomatic, like a left main or a say near total occlusion of a carotid, then probably I think it would become again a heart team approach, though it's nowhere mentioned per se in the guidelines to have a heart team approach when you're dealing with this. Yeah. But this is one gray area where probably you need to involve a neurologist, a neurointerventionist, a cardiothoracic surgeon, or maybe a cardiologist.
And nowadays, Kamal, we are also getting the opinion of neurophysician also. Patient who are having symptomatic carotid or a patient who had a symptom of carotid, we do get their help whether we should go and intervene in the carotids or not. And personally, I believe that it's always, rather than pulling them, the first slide which was showed by Dr. Rahul, we should put a ladder rather than the rope between them. And we both of us should come together. What I have experienced is that if we undergo a carotid intervention with a stenting, at least it gives some amount of relief while operating. And if possible, that stage approach really helps to the benefit of patients, rather than we should not think of ourselves or who is right or who is wrong. In the betterment of patient, that hybrid approach definitely helps.
Definitely.
So what about the
problem arises if there is disease in some other territories like femorals. Just imagine that your femorals are too bad for any access. So what would you do?
Then we explain the patient, because in that case, the patient undergoing peripheral vascular disease with coronary artery bypass disease, the risk definitely goes higher. And in that case, we have to decide whether the patient is really symptomatic for coronaries or not. That is most important. If it requires a coronary intervention, and that is a surgical intervention, then definitely risk goes very high.
No, sir.
Dr. Rahul, your choice of, sorry, Dr. Girish, you were saying. I was asking Dr. Rahul about choice of DAPT.
So,
but if the same
aspirin
patient,
and
Rahul, sorry, go on.
no, the dual antiplatelet would be aspirin and clopidogrel, and usually few cases which we have done where the surgeon was comfortable with, and we can stop after 7 to 10 days for a short while the antiplatelets, and single ecosprin can be continued. Surgeons can operate on a 75 milligram ecosprin, and usually it's not an issue. That's what I feel.
Carotid stents don't behave like drug-eluting stents. That's the fun of it. The caripers are huge. These are usually self-expanding stents, and the risk of stent thrombosis does not arise as you look at in the bare metal stents. So I think it's 7-10 days window is good enough. That's what I believe. Any counters on that? Dr. Anandan, Dr. Girish, Dr. Jignesh Bhai, Karthik?
Fair enough. I think 7 days is good enough. But there are people, there are surgeons who do on the same day. Because many a times you see that if there is an indication, if there is an emergency indication, they often do on dual antiplatelets. Not that they don't do it. So, but yes, sometimes the scenario might change if there is an associated atrial fibrillation where your anticoagulation is again indicated. There you might think whether to do or not to do. So that might change. That scenario might change.
No, in cases of renal artery disease, we do advise renal artery stenting antiplatelets for 4 to 6 weeks, and then later we operate the patient.
Renals itself have become so much debatable. I think next year we need to keep that debate as well. So I'll have to create bilateral renal artery stenosis, DTPA functional, and creatinine rising, and then patient needs a on-pump surgery. So something like that, and then we can debate what to do first.
So just to know from the surgeon's point of view, like for CAS, we have these embolic protection devices. So how is the procedure for carotid endarterectomy actually performed? Just if you can just briefly tell us.
You have the same, but the time permits, I can show you the video. There are balloons and stents are available, which is just like a EPD, which will prevent a distal embolization as well as it will perfuse the distal bed. So the video I have. Few more slide was there, but due to lack of time, I cannot show you.
Yeah, okay.
If you want, I can share with you. The video I can share with you.
Yeah, please. Thank you.
I think this procedure can be done on a local anesthesia, right?
Sir,
this is our doubt. See, actually, the debate is a debate. We just share things, but regarding the procedure, there is a serious misunderstanding between each of our procedures. I mean, I find that educating each other should be more important than just holding a simple factual debate about articles. Because more we know about your procedures, we can actually choose the right patients for you, and you can also send the right kind of patients to us, so that it becomes a win-win situation for both. Yeah,
I think we should move to next session.
Okay. Thanks, Dr. Kamal.
Thank you.
It was a nice discussion on the very difficult topic. And with that, I would end this session. And Dr. Kamal for the next session, please.
Thank you, chairpersons, moderators, and speakers. Thank you for joining and for a wonderful session and wonderful talk and deliberation.